As announced yesterday, we will start today with a lecture of Matthias Duchaver, Understanding of Atrial Tachycardias, an emphasis on topology, and then we will continue with the program which is dedicated to cardioneuroablation. So Matthias, please.
I still have the slides from Pascal. So maybe I have the slides here from Dr. Santangeli. Maybe it's better if he starts. It's easier. Okay, good morning, everybody. Happy to give a talk on topology because I think it's brand new. And let me first start with this slide. And it starts with a despite. I know we all have high procedural termination rates when we are treating atrial tachycardia. I know that we have a favorable one-year outcome when we treat atrial tachycardia with catheter ablation. Why am I saying this? Because when I give this talk, there is always pushback that people say, what are you talking about? We all know this. Well, I try to remind in the beginning of the talk people that ablation is often associated with an unclear case narrative. If you ask your colleague, what did you do yesterday in the ATAC, and he starts to explain all the steps and the maps, it's an unclear case narrative. There is often a need for remapping. Sometimes the ATAC continues, and you are ablating, you don't understand. Sometimes it goes to a second atrial tachycardia. And this uncertainty, I'm pretty sure, sometimes lead to a premature switch, a new line, a potentially harmful line. And at the end of the day, for me, catheter ablation is like taking a walk with the dog, but it's the dog that is leading. Is that a problem? No. But I try to explain how you can control better your procedure. The reason why the procedures are not always going as planned is because there are widespread misconceptions, and of this I'm pretty sure. One of the misconceptions is that a single loop and not a dual loop is the dominant mechanism. It's not correct. Number two, loops characterized by long entrainment, they should be considered passive, is one of the misconceptions. It's not correct. And number three, selective ablation of the active circuit may terminate the second passive circuit. That's not correct. And the reason I know this is because when we submit papers, we always get reviewers back and forth. So I really think I know what is living in the EP community. We have two papers on atrial topology, and this is the first one. It was, I have to thank Paul Wang from CircEP. It's called Atrial Topology for a Unified Understanding. And as you can see on the left, you have the clinicians from the team of Bruges. On the right, you have the Department of Physics and Astronomy, the University of Ghent, led by Nele van der Sikkel. And it's by discussing cases many years ago that we came up with this new theory of topology. And it's now being picked up by Stanley Natel and others when discussing atrial fibrillation and ventricular tachycardia. So it's a concept that will stay there, I think, when understanding reentry. The second paper is, which we will discuss, what can you do with topology to improve your ablation procedures? Let's start with computational reentrant atrial tachycardia and with topology. What is topology? Topology is it's a basic form of geometry. It's called clay geometry or rubber geometry. It's concerned with the properties of a geometric object that are preserved under continuous deformation. You cannot rip it apart, but continuously deforming. That's topology. For a topologist, a donut is the same as a cup of coffee. If you take this donut and you play with your hands, you will see that without ripping the structure, you get a cup of coffee. That's topology, the mathematics around. If you know this, an atrium or any other structure in the heart is nothing more than a closed sphere with a finite number of holes or boundaries. So for a topologist, an atrium is nothing more than a closed sphere with boundaries. So it should be a good idea for a computational model to understand reentrant atrial tachycardia. And that's what we did. We started with computational modeling, and then we went to clinical atrial tachycardia. And these are the results of the computational modeling. There is certain action potentials, conduction velocity you put on the model. You make a 3D sphere. You can insert boundaries. What is a boundary? It's a valve, it's a scar. You can play with the size. You can play with the number of boundaries. And this is what we observed in X number of computational ATACs. If you have a sphere with 2 boundaries, you will have a single loop. It will rotate around one boundary, and you will have a counter rotation around the other boundary, but at the end you have a single loop. Think about a flutter where the crista terminalis is blocked and you go around the tricuspid valve. The nice thing about this 2B atria, that's how we call them, 2B topology, whatever you do from an ablation perspective, if you connect both boundaries, wherever in the atrium, you will have termination. Easy. The moment you have 3 boundaries, so same model, 3 boundaries, different sizes, and you induce atrial tachycardia, you always will have a dual loop tachycardia. Always. There will be one boundary, which we call the critical boundary, which is enveloped by complete rotation, and you will have a second critical boundary, which is enveloped by incomplete rotation. But basically, the rotation is all there. The third boundary is called the non-critical boundary, and it's activated by parallel activation. You can look at all your activation maps you have in the lab. It will always look like this. When you do PPI, some people like entrainment, some people don't like entrainment. This critical boundary will have a perfect post-pacing interval, whereas the CB2, which I will refer to CB2, it will have a long PPI. And that post-pacing interval, by the way, is nothing more than the revolution time around this larger critical boundary. So the PPI measured at CB2 is nothing more than the revolution time. And now it gets interesting, because now you can start to make mistakes with ablation, because ablation is connecting boundaries. If you connect both critical boundaries, it will always terminate. If you connect the CB1, so the boundary where the cycle length is the same as the revolution time, and you connect it to a non-critical boundary, deliberately or by mistake, you will have a prolongation. Why? Because it will convert to a 2B atrium with a single loop, and it will turn around to CB2, and it will get that longer cycle length. So actually, the cycle length prolongation is predicted by that longer PPI you measured at the CB2. And then if you connect, by mistake or deliberately, CB2 to NCB, the atrial tachycardia will continue around the CB1, so the cycle length will not change. So these are the 6 key elements of the computational modeling. Number 1, you always have paired rotation around 2 critical boundaries in reentry. Santucci wrote a paper about this in Jackie P. Always 2 critical boundaries. Number 2, if you have a 2B sphere, it's a single loop. If you have a 3B sphere, 4B sphere, 5Bs, it will always be 2 loops. Yes, there will be asymmetric, but they will be rotating around the 2 critical boundaries. Number 4, you need to connect the CBs. If you connect, on the other hand, the CB1 to an NCB, it will lead to continuation of the ATAC in a longer cycle length, and you can predict to what extent the cycle length will prolong. This was predicted. This was not just a finding. But if I would have started with the mathematics, you would have said, well, what is this all about? There is a law in topology that states that the sum of topological charges of all boundaries on a closed surface equals 0. And if you look at a 2-boundary model, you will see rotation here. It's called a topological charge of +1. You have a counter rotation here. It's -1. The sum of charges is 0. In a 3-boundary model, you see +1 and -1, and this parallel activation has a topological charge of 0. The sum is again 0. So it's a law that in reentry, the sum of topological charges is always 0. This one I will skip. What is important, what we never observed, and what you read daily in case reports, but is incorrect, an atrium with 1 boundary, with a single loop, doesn't exist. What also doesn't exist is an atrium with 2 boundaries, with one single loop. You read it everywhere. It doesn't exist, and parallel activation around the other boundary. An atrium with 3 boundaries, with 1 loop, 2 parallel activations, doesn't exist. 2 independent loops without a common channel, doesn't exist. 3 loops, you will read it in literature, doesn't exist. The idea that selective ablation of the active circuit would lead to ATAC termination, we read it, we get it from reviewers. It will never terminate, it will always continue. And this one is also nice. These are 4 boundaries. Look, this figure of 8 with 4 boundaries. The idea that you would terminate this tachycardia by ablating this CB1 to NCB and this CB2 to NCB, it won't happen. We just had to validate this now in clinical ATAC, because of course in atrial tachycardia there is dispersion in conduction velocity and refractoriness, there's fibrosis. The boundaries are sometimes scars, sometimes valves. So we had to validate this, and we did this in our CERC EP paper. We had 131 cases. And these were cases that had a very detailed case report. It was retrospective. They were all ablated with conventional principles. These are the patient characteristics. What we did, we looked back at all these 131 cases, and we looked, what is the topological mechanism, according to what we learned? Number 2, does the entrainment response correspond to the topological mechanism? And what did we observe regarding ablation? And here you see one case. Again, it's the first paper, it's a retrospective analysis. This case was described as followed. You have a loop counterclockwise around the right veins. In that case, we did entrainment. It's not mandatory, but we did entrainment, and we had nice entrainment intervals suggesting that this was the active circuit, and we had black PPIs further away towards the mitral valve. So at that time, 5 years ago, it was interpreted as an active circuit around the right PVs. So let's do a roofline. It should stop. Clearly, we read the case report, no termination. The tachycardia prolonged. No worries, it's what you read in case reports. Patient converted to a second tachycardia, whatever. Oh, we have a perimitral flutter. And now the PPI corresponds to the perimitral flutter. Okay, I read in the case report, we did a lateral mitral line and it terminated. This is pure topology. How do I look at the case now? Well, this is an atrium with 3 boundaries. The roof is conducting, the mitral is conducting. So there must be 2 loops. Yes, there is a loop around the right veins. But there is also, if you look carefully, and it's not so spectacular, there is a second loop here around the mitral valve. There is a second loop. And yes, there is a longer PPI, but that's just because it has a longer revolution time. So actually, this is CB1 and this is CB2. And what we did with the roof is nothing more than a CB1 to NCB line. And if you make this line, which I depicted here, you will convert the tachycardia in what we call a single loop in a 2B atrium. So all the 6 key elements, they were confirmed in this case. Now we had to repeat it 131 times, and that's what we did. And each reentrant case, we see paired rotation around 2 critical boundaries. And what are the boundaries? Typically mitral valve, left veins, right veins, isolated scar, tricuspid valve, SVC. Number 2, what is the dominant topology in your cases? It's 3 boundaries and more. It's 3 boundaries and more, meaning it's dual loop. 62% of the cases. And actually, the moment you have a scar-related tachycardia, it's 95%. So you can anticipate dual loop tachycardia. If you have a patient that is never ablated before, it's 100% that you will have 3 boundaries or more. We also confirmed the observation that if you connect the first critical boundary to a non-critical boundary, which was performed in 20 cases, that it never terminated the attack, but that it prolonged according to the entrainment interval. This is the correlation curve we did in all our clinical ATAC cases. So we confirmed this. A 2B topology, when do you have it? Yesterday there was a beautiful case from Peter. In the live case, you had this roof posterior block, perimitral, That was a nice single loop case. It's this case. Roof is blocked and you have a single loop around the perimitral. But it's only in 38% of the cases. We never observed a single critical boundary, we never observed triple critical boundaries, and we never observed that selective ablation terminated ATAC. Now we integrated our thinking, that is the next step, in our workflow of mapping and ablation. Basically what you need to do, you have to identify the two critical boundaries. There is no reason to do entrainment. We are not interested in the hierarchy of CB1 and CB2. It's enough to know what is CB and what is the other CB, and you just connect both CBs. And that's what we do now. We take the dog for a walk in the park, but now we are in control, and we see 99% of the cases. We don't see anything unpredicted regarding TCL changes. One case I will show. I will take this case. Yeah, well, this case. It's a patient, tachycardia cycle length 290 milliseconds, left atrial volume 155 milliliter. Conventional thinking might end with the observation that there is a loop clockwise around an anterior scar. I'm not saying everybody would do this, but it might end there. You have good PPIs, and then if this is the active circuit, I could ablate and maybe connect to the right veins, or I could connect maybe to the left veins, or I could connect to the mitral valve. Now, thinking back topology, this is a patient never ablated before. So you have more than 3 boundaries by definition. Actually, in this case, we have 4 boundaries, so there must be a second loop. And then if this is the rotation, just look at the neighbors. It can either rotate around the right veins, left veins, around the mitral valve, or a combination of both. In this case, despite the long PPIs, the second loop was found around the mitral valve. So actually, if you want to terminate this tachycardia, meaning if you want to know what is the critical isthmus, the only lesion that will terminate this tachycardia is this set of ablations. I'm not saying that this is the end state of your ablation procedure. Sometimes we have to do more lines and we have to prevent recurrence. But to guide your workflow, we propose topological thinking to terminate with control your tachycardia. And with this example, I'd like to end my presentation.
Thank you very much. It's a great concept. I think people should read these papers, and they should learn. And yeah, any questions or comments?
Hey, Pascal.
Yes, there was a great talk. Some clarification. How do you exactly understand what CB2 is? Because CB1, I guess you can use activation and entrainment. But CB2 is the one that shows rotational activity around it, that is slower than the primary one. So how do you go, in other words, the differentiation between non-critical boundary and CB2?
So, good point. Let's take this case. You see a rotation on the anterior scar. So it's a critical boundary. This patient, it's another case, never ablated before. I know there must be a second rotation. So I'm not talking already about CB1 and CB2. I'm just saying, where is the other rotation? And you will look at all your maps and you will see it. All the colors of activation are present. Or if you look at the electrograms, all the LATs will be present. In this case, the second loop, you just have to turn your map. It's here around a line of block anterior of the left veins. The mirror image being what is the non-critical boundary is also important because sometimes it's more clear. You will see nice embracing activation. Just turn your map, look at it, that you see both sides of the boundary, and you will see parallel activation in each of your maps. The last step, who is CB1 and CB2? The first part of the answer could be, I don't care, because just connecting them is enough. On the other hand, if you like to do entrainment for other reasons, there where you have the longer PPI will be your second critical boundary. You will be surprised that your second critical boundary is not characterized by something that we call incomplete rotation. It's almost always complete. It's not that you see this retrograde activation. Look at your maps, it will be almost complete. So, CB, rotation, non-CB, parallel activation. If you want to know CB2, do entrainment. It's rare to see it by looking at incomplete activation. Good question.
Thank you. Thank you for the talk. Quick question. By examining your previous cases, in retrospect, would you do less ablation if you knew that information? Would you do less lines?
I have to be honest there. Based upon our results, I cannot claim any statement, because what we do after we terminate, we re-ablate the lines that we made before. So we do our roof, we do our lateral mitral line if we did it in the first procedure. So what we showed is that at the end of the procedure, we almost have always a single boundary atrium. Now, the nice thing is that I have a few cases, 20, 30, 40, 50 out of 190, where we didn't ablate until a single boundary. And we left the mitral open or the roof open. And these cases tend to be, but that's early, they tend to be as good as the ones where we ablated until a single boundary. So I like your question. It's work in progress.
When we do now do cases after, for instance, Farapulse ablation, where we do in persistent PVI plus posterior wall, sometimes even down to the coronary sinus, and they have some recurrence of atrial arrhythmias. Often we see that it's really from the septum, which I've never seen so many before. So it is traveling between both atria, through the Bachmann's bundle and down through some connections to coronary sinus, for instance. So it's very difficult sometimes to understand from the map. So you do entrainment in these areas, and then based on this, we basically decide so how this fit. If you have these two atria and you have septum, which is more complex than cases where you showed here, how you look at this in topological terms?
Yeah, two things really interesting. This is part one of my answer. We did evaluate the incidence of atrial tachycardia after simple PVI and posterior wall isolation with pentaspline. This is now accepted for JACC, EP. It's 4,000 patients, multicentric. First, what we observed is the incidence of ATAC is lower than expected after radiofrequency. That's number one. That's good news. If you look at the mechanisms, even with PVI and posterior wall isolation, we tend to see slightly more scar-related tachycardia from the anterior wall, although we didn't touch the anterior wall. Interesting. I don't know what it is. And then there is this second part of your question. The moment you start to make anterior lines and you start to ablate the septum, Bachmann bundle, you induce B atrial tachycardias. I've never seen B atrial tachycardias before, and now the B atrial tachycardias come to our lab. Topologically, they're very simple to explain. Look what happens in the B atrial tachycardia. You get activation of the atrium via this input. All the boundaries you will see there are embraced by parallel activation. The topological charge is 0 in the left atrium, but also for the right atrium. So physically, it behaves like re-entry should behave, but it's a new tachycardia that we are now seeing more and more.
I can confirm that we see sometimes this localized re-entry on anterior wall, even though we did not ablate there. So I can confirm after ablation of posterior wall.
Yeah.
But my explanation is that we never could see it before because with RF or cryo, there was never such a complete ablation of posterior wall and pulmonary veins. So you had always something to do with pulmonary veins, and so this is now a completely new scenario. And when you ablate incompletely anterior line in a left atrium, you can then expect this biatrial tachycardia.
Yeah, absolutely. So we unmasked that something was already there in RF, that's we also write in the paper, because we are doing a better job at veins in posterior wall.
Andreas, I have troubles because when Peppa mentioned this several energies we used before, the pentaspline, for example, let's make an example of pentaspline. After the index procedure, you have posterior wall, you have like PVI, because of stunning, because of all the, cells are a little bit affected. It's not predictable after the index procedure, immediately after the index procedure, what's happened, okay? So we can create, even with PFA logically, we can create a substrate for potential other re-entries. So I would love to have, immediately after the index procedure, some parameter predicted, okay, that's potential rotational or not.
I understand. It's the problem of stunning, and how long do you have to wait before you see what the actual lesion will be at 3 months? I agree.
I just observed in some cases where we did with some of these technologies, pulmonary vein isolation, and because the atrium is often very small, I realized when we are used to look at 3D maps, and you have always map of atrium like this, big on the screen, so you believe that the atrium is quite big. If you have printouts, like my technicians do 3D printouts from CTs, so atrium is actually small like this. The posterior wall is very small. So if you take a 35 millimeter big tool, you cover basically with 1 or 2 applications, you can cover most of the posterior wall. So if you do some PV isolation, antral isolation, you can be very close, both circles together in posterior wall. And we saw that there is sometimes like block, even though they are not touching, but after 10 minutes or 15 minutes, it recovers. And also voltage recovers because it's a stunning. So there might be really like 1 centimeter in between, and it is stunned, and then it recovers. So I would recommend if you happen to have this scenario to close this line, because this narrow isthmus, because otherwise you may have more ATs. And in Euphoria and other trials, they had a lot of recurrences of atrial tachycardia. When I read how many times they used 35 millimeter tool, it was quite often. So because then you are basically covering most of the posterior wall. So you have to be aware of all these things. And there's quite interesting phenomena now today with all these pulse field technologies, because this is something completely new we haven't seen before when we used the RF mainly or cryo.
Yeah, I agree.
Okay, any other comment or question? If not, thank you very much. It was really enjoyable talk. Thank you for coming. Welcome. So now I have honor to introduce again Dr. Paixão from Brazil. As you all know, he's father of cardioneuroablation. So he will give us some talk, let's say, about the history of cardioneuroablation. And it was interesting that he described this in 2005, and it took another 10 years before we picked up more or less this strategy. And as I mentioned in my opening talk, in 2015, we did here first a live case. And then, since then, I think it became now a boom of cardioneuroablation. So, please.
Thank you, Professor Kausner. Thank you, Professor Peter. It's a great honor for me to be here, and I would like to repeat that you are inaugurating the new fashion of the modern electrophysiology Congress. And we are going to talk about history of cardioneuroablation and atrial fibrillation nest. And let's talk about the origin of cardioneuroablation, the origin of in the Congress was here in Prague in your Congress. And I was studying in the 90s the origin of cardioneuroablation, and we found the very well connected muscle, the compact myocardium, and the loose muscle, the fibrillar myocardium, and they are present in the normal heart. And obviously, it is easy to be identified by spectral analysis, and this, the fibrillar myocardium constitutes the atrial fibrillation nest. And comparing these two myocardium is very interesting because because the atrial fibrillation nest present disorganization during progressive atrial pacing. And it doesn't occur with the compact myocardium. This disorganization of the fibrillar myocardium causes electrical resonance that maintains the atrial fibrillation, because the fibrillar myocardium acts as active resonant arm during the atrial fibrillation, and the compact myocardium act as a passive conductor during the atrial fibrillation. And also, here we can see an atrial fibrillation nest and a compact myocardium. They present similar electrical activity during sinus rhythm. However, during atrial fibrillation, the compact myocardium shows organized the electrical activity, while the fibrillar myocardium presents a very disorganized, high-frequency electrical activity, and the fibrillar myocardium are related to innervation entry in the atrial wall. It causes even the disconnection between cells, and these areas, if ablated, stop the atrial fibrillation. And I would like to show you the new concept about atrial fibrillation nest. And inside of the atrial fibrillation nest that are very narrow areas, very discrete areas in the atrial wall, we can see that there is a specific type of micro-reentry that we can observe during spectral analysis. It is the fractal micro-reentry that occurs inside of the atrial fibrillation nest, and the atrial fibrillation nest present boundaries. These boundaries are inner boundary that is caused by high frequency, and the outer boundary that is caused by the atrial refractory period. So it is difficult to enter to the atrial fibrillation nest due to high frequency, and it is a little bit difficult to out from the atrial fibrillation nest due to atrial refractory period. So eliminating the atrial fibrillation nest, it's possible to eliminate the atrial fibrillation and also to eliminate the vagal innervation. So in that time, we found that the atrial fibrillation nests are very near to the vagal innervation, and eliminating of the AF nest caused a very significant vagal denervation that gives origin to the cardioneuroablation. And here we can see that the cardioneuroablation is based on elimination mainly of the postganglionic vagal neuron that is located in the atrial wall, while the neurons of the sympathetic and sensory system are located far from the heart. So the ablating the endocardial surface of the atrial wall is possible to eliminate mainly the parasympathetic system, and it makes possible to treat functional bradyarrhythmias, and also the most important for us nowadays is elimination of the atrial fibrillation. And how to perform cardioneuroablation? And in that time, we had no fractionation software, so we use it to filter the signals and to study the spectrum. And here we can see this signal that's very important, signal from 300 to 500 hertz. This signal represents, if it is shifty to the left, represents innervation. And if it is shifted to the right, represents fibrosis. So in normal heart, to eliminating this frequency is enough to eliminate the innervation and eliminate the atrial fibrillation. And in order to get more precise procedure, we developed in 2006 the fractionation software that nowadays exists in about systems. This fractionation shows in clear areas, in light areas, the areas with high probability of nervation, the atrial fibrillation nest, and in purple areas, we can see the compact myocardium that present low probability of innervation. Here we can see the main points to be ablated in order to get the cardioneuroablation. They are now very well known, like the area between aorta and superior vena cava, the insertion of the right pulmonary veins, the insertion of the coronary sinus, insertion of left pulmonary veins, and a very important area that is called the area P, or P point, that's located between the insertion of the right pulmonary veins and fossa ovalis in the left atrium. And this area are related to innervation of the sinus node. And how to measure the denervation? In order to control the denervation in the first time, we have been using to study the sinus rate increase to Wenckebuss point increase, the sinus node recovery time reduction, and obviously at the end, the elimination of the atropine response. However, these parameters are not completely reliable. So we developed the extracardiac vagus stimulation that is obtained by advancing a catheter from inside of the internal jugular vein. In that point, it's possible to stimulate the vagus without contact. And obviously, it makes possible to stimulate the vagus and cause a sinus arrest. The same sinus arrest we observed during head aptitude test in cardioinhibitory syncope. And after cardioneuroablation, again, the same stimulation shows that there is no more vagal effect. There is no more asystole, no AV block. So it makes possible to have a control of the cardioneuroablation procedure. And in order to see the value of the extracardiac vagal stimulation, we compare a population of patients submitted to cardioneuroablation with vagal stimulation and without vagal stimulation. And we found that the patients with cardioneuroablation controlled by vagal stimulation present in about 5 times less recurrence. And nowadays, due to the selectivity of the vagus, it's possible to do a cardioneuroablation, and a specific cardioneuroablation for example, for sinus arrest, and in order to get a more specific ablation and avoid spreading the ablation in the whole atria. And also, it's possible to get a tailored cardioneuroablation for example, for functional AV block without ablating, for example, the ganglionated plexi that innervated the sinus node. And obviously, it's very important that there is nowadays a specific cardioneuroablation for atrial fibrillation treatment. And let's see something about the indications and results. Here, the main indication of cardioneuroablation is the cardioinhibitory syncope. Like in this case, we can see a very long pause, a very long asystole that causes syncope. And here we can see a short workflow about the treatment of the vasovagal syncope. And first of all, it's necessary to education and lifestyle intervention. And obviously, we can see do educational orientation for the patient, physical counter pressure, and salt and fluid intake in order to treat clinically the vasovagal syncope. If it is not work, we have to medical treatment like midodrine, fluorocortisone, beta blockers, and antidepressive drugs and norepinephrine drugs. If there is recurrence of the medical treatment, okay, we are ready to do the invasive treatment that may be the cardioneuroablation or the conventional pacemaker. And here we can see something about the results. The results of cardioneuroablation are better than the clinical and even better than some trials of pacemakers. Here we can see in the red line that the result of cardioneuroablation is going well, and one very important result is that the results in patients with less 40 years and more than 40 years age are the same. So it's not necessary to share the patients if they are younger or older than 40 years age. And here you know the results of the Roman trial that showed good results with cardioneuroablation compared to clinical treatment in patients with cardioinhibitory syncope. And one very important find during this trial is that there was a significant improvement of the life, quality of life of these patients. So I understand because the vagus is a nerve that was created to cool blood animals, and we are hot. We have a hot blood. We have warm blood. We are warm blood animals. So probably eliminating the vagus in these patients causes an increase of quality of life. Contraindications of cardioneuroablation. The first one is poor response to atropine. The second, organic AV block. The third one, pathological HV interval. And fourth one, abnormal response to ajmaline. I think these contraindications are crucial and must be in mind in any indication of cardioneuroablation. Nowadays, we have a lot of meta-analysis. We have no time to comment these meta-analysis, but there are a lot of meta-analysis ongoing, but they found that the cardioneuroablation are finding very good results in treatment of the cardioinhibitory syncope. So I think probably in the next years, the cardioneuroablation will be included in the guidelines. Practical insights in cardioneuroablation. What is the best test for indication in sinus bradycardia? The best test is positive atropine test. What is the best test to contraindicate in sinus bradycardia is negative atropine test. I think to get a good response of atropine in order to indicate cardioneuroablation is necessary to get at least a heart rate of 8 beats per minute. I think in this situation, the result must be absolutely not relative to the basal frequency. What are the best tests to contraindicate in atrioventricular block? Is the Wenckebach, the situation when the Wenckebach's point does not respond to atropine test. Also, the HP lesion in EP study, and also abnormal ajmaline test. I think it is very important because some patients present high degree of block that may be caused by severe lesions and subclinical lesions of the His-Purkinje system. So we have to be to take care about this. And what is the best test for clinical follow-up? Is the heart rate variability, the Holter, the head-up tilt test, atropine in the late phase, and obviously the looper. And what is the best endpoint for atrial fibrillation ablation in our lab is the negative VAFT protocol. So to end our procedures of atrial fibrillation ablation, we have to eliminate completely the vagus effect in the third domain, that is the domain of atrial wall. So for us, the best test for atrial fibrillation ablation is the VAFT negative. And in the sinus node, the negative atropine test for sinus dysfunction is extremely important to exclude the cardioneuroablation. So in sinus node, negative atropine test do not indicate the cardioneuroablation. In AV conduction, do not indicate the cardioneuroablation in cases of MOBS type 2 AV block, in cases of AV nodal lesion non-responsive to atropine, and in cases of split of H potential, in cases of long HV interval, and in cases of abnormal Ashmalin test. And obviously, for that one that like reading about this area, we have published a book that shows the origin of the cardio-inhibitory reflex from 500 million years before. And the origin of the cardio-inhibitory reflex is the same origin of atrial fibrillation. It's very interesting because there are origin of these arrhythmias, the brady and tachyarrhythmia, the cardio-inhibitory syncope, and atrial fibrillation in the same root in very, very old animals. So thank you very much for your kind attention.
Thank you very much. Any questions, comments?
Thank you for the nice talk. Is there any value of the VAFIT? I don't know if I pronounce it correct, VAFIT. Yes. Is there any role in non-AF patients in cardioneuromodulation, so in non-AF patients?
Yes. Yes, typically we do the VAFT in our procedures of cardioneuroablation because we can see if we eliminate the sinus node, the arrest, we are eliminating the first vagal domain. If we eliminate the high degree AV block, we are eliminating the second domain. And if we get the negative VAFT, we are correcting the third vagal domain that is located in the atrial wall. So we have been observing the VAFT in our patients. For example, in patients presenting rate tachycardia, in AV node rate tachycardia. It's typically normal present the positive VAFT, but showing only a non-sustained atrial fibrillation. In patients that present atrial fibrillation, typically they present VAFT by long time. The fibrillation is long. And obviously, if there is more pathological condition of the atrial wall, the VAFT causes even sustained atrial fibrillation. So we are studying is a new parameter that we have to know about it. But in our experience, probably the most important application of the VAFT is in redo procedures of atrial fibrillation because it shows several nuances about the procedure of the redo in recurrence of AFib.
I think, in my opinion, we need to perform a randomized trial to see if vagal denervation helps to improve results of AFib ablation. And we have now very nice tool like Sphere 9, so we can do only isolation of pulmonary veins with pulse field, and we can do anterior part with RF. If you do RF, you always do denervation, which is durable. So this trial like this could answer the question because there are so many variables in a play, and I think without such a strict trial, we cannot answer these questions.
Or we need to have a different pulse field to attack ganglionic plexi, right?
No, but I think that
It's there.
For the next Congress in Prague. A different
More like
energy
this.
is for you to test.
Yes.
It's a different energy.
Yes. Yeah.
any other comment or question? If not, thank you very much.
Okay, so next speaker is Pascal Saltagnelli, and actually he's from Cleveland, USA, and he will guide us for cardioneuroablation with ice.
Thank you
Please,
very much,
Pascal.
Peter. Thanks, Joseph, for the kind invitation. The best time of the year to be here, beautiful weather, and this is a great conference because everything is in a single room, so we have discussion, which is not common to see in other conferences. So this is an approach that we designed to simplify things, how we select the targets for cardioneuroablation. Quick word about the anatomy here. There is an extrinsic innervation of the heart, which we don't touch, of course, with this. There is an intrinsic one that tends to be clustered in specific regions. There is a paraseptal region here, where the ganglionic plexi are. There is a superior paraseptal that provides innervation to the sinus node, and an inferior paraseptal that predominantly provides parasympathetic innervation to the AV node. And then if you go leftward, there are other ganglia around the left pulmonary veins. Now, the interesting part about these left ganglia here, they connect to the sinus node and AV node via the paraseptal ganglia. That's why in the radiofrequency era, if you start your pulmonary vein isolation on the left side, sometimes you do see vagal pauses. But if you start the pulmonary vein isolation from the right side, and then you injure this paraseptal ganglia and you go to the left side, you pretty much never see vagal pauses. So in order for the left ganglia to connect to your sinus node or AV node, they have to utilize bridging with the right paraseptal ganglia, which is important for the approach that I'm going to show you later. All right, so the fat pads are actually known anatomical structures. They're very well known by the surgeons. I don't know if you're familiar with this old study by Pokushala where they injected Botox, so a neurotransmitter modulator and blocker in the paraseptal ganglia to prevent post-surgical atrial fibrillation. This was an example where they are. But typically, surgeons do know that they are within the so-called Waterston groove, which is the separation between the right atrium and the left atrium. And of course, there is above and below the fossa valis. And here, typically, again, the two main targets are the right superior paraseptal ganglia, right superior GP, and inferior paraseptal ganglia, depending whether you're doing a cardioneuroablation to denervate predominantly the sinus node versus the AV node. So how do we find these septal ganglia here? So it's quite simple. When you advance your eyes all the way up to the SVC, superior vena cava, and you clock towards the septum, you will see three structures. The very first structure, the near-field one, is the SVC at the junction with the right atrium here. The second structure is the left atrium. I'm going to pause here. 1 second, let me see if I can pause it. Maybe, oh, sorry. Let me go back to the pointer. All right, perfect. I'm going to stop you here. The second structure that you see is the left atrium here, and you see some of the right superior pulmonary vein on this way. This circular structure is the right pulmonic artery. In this space between the RPA, the SVC, and the right superior pulmonary vein, there is this triangular portion that is fat, and this is the right paraseptal, superior paraseptal ganglion. What you can do with intracardiac echo, you can simply look at that, but you can also reconstruct it. So here with carto integration, you can see there is a reconstruction of this paraseptal, right superior paraseptal fat pad. It's imported directly within the map, and that's the only target you need, really, for sinus node denervation. You can also reconstruct the right and the left atrium. In this case, the reconstruction was done with ice. But simply, this area, which is a very common area that is used for an anatomical approach, always is in between the SVC, the right superior pulmonary vein, and above here you see the right PA that you don't see in this case, but you can map in this little pericardial space here. You see the way this is done is very simple. The mapper freezes the eyes picture and it starts reconstructing this area, which gets automatically imported in your procedure, in your map. So for the inferior paraseptal ganglion, which is the one that you want to target for AV nodal denervation, you pull back the eyes towards the junction between the IVC and the right atrium. And here again, the very first structure that you see is the junction between the IVC and the right atrium. This part here is the coronary sinus here, ostium. Here, you would see the right inferior pulmonary vein. You don't see it much because it's more of an anterior view. And this area of fat here is the inferior paraseptal region. And here, this is an image from our surgical colleagues when I try to correlate intracardiac echo with surgery, where they put a needle in the right inferior paraseptal ganglion, and I can actually see with eyes that this was really confirmed to be the same area. And similar to the right superior paraseptal ganglion, here, once you image it, it's simply you can freeze the image, you can draw it, and this will be automatically imported in your map. And that's really all you need to define your ablation strategy, because that's your ablation target. It's not based on any other form of surrogate markers like electrograms and so forth. It's simply by visualization of where the fat pads are. The other benefit of intracardiac echo is you can also look at structures that you don't want to injure. And of course, this is something that is quite unique. And I did personally learn this from orthopedic surgeons when they do injections under ultrasound of nerves. And essentially, you can see if you monitor, if you push your eyes all the way to the SVC and you clock your eyes in the posteroceptal region, you see this stripe of myelin fibers, of fat, essentially. And this one is the right phrenic nerve. You can reconstruct it and import it with the eyes. And this correlates, and hopefully later we're going to show you a nice example of this. This will always correlate with capture of the phrenic nerve with output pacing. Of course, you can see here, you can also reconstruct the distance between your target or your left atrium and the phrenic nerve. And this explains why sometimes you simply cannot capture the right phrenic nerve from the left atrium because there is too much anatomical distance in that location. So another nice application of this ICE technology for this. All right, this is a case presentation, 28-year-old woman with recurrent vasovagal syncope, ILR was implanted. And again, for this type of procedure, it's very important to have a proper patient selection. You need to have demonstration of a cardioinhibitory response with syncope. And most of our cases do have already an ILR implanted. It was a sinus arrest and structurally normal heart. We have learned this from Professor Pachon, and as I think this is really makes our endpoint of the procedure cleaner and more reproducible. Here we do extra cardiac vagal stimulation. Usually we start from the right IJ for patients with sinus node arrest. We have to move to the left IJ with patients that have predominantly AV nodal arrest because the left carotid sinus predominantly innervates the AV node as well as the ventricle. But here you can see with extracardiac vagal stimulation, you clearly have reproduction of sinus arrest in this patient before the procedure. So here is a little bit sped up, but it's the same story. You can see the eyes live on the left side. You see the right PA. You see part of the right superior pulmonary vein, the SVC, and this fat pad here. So the mapper freezes that specific area and reconstructs the phrenic nerve here, the fat pad here, which gets automatically imported within the map. So that will serve as our endpoint, in some ways, our anatomical target to ablate from the left atrium, and then from the right atrium, we always use a bilateral approach for these type of cases. And here you can see, just live, as soon as we have imported the fat pad there, we start ablating here. And here you see this is live ablation. As soon as ablation goes on, the baseline heart rate is 70. Usually within the first or second radiofrequency ablation, usually we start from the center of the fat pad that has been reconstructed. You can see an increase in the heart rate from 70 to 80, and in this case, we'll go all the way up to 100 beats per minute. It was quite vigorous response. You don't always see that. We always accept at least 25% to 30% increase in the heart rate. But you can see here with ablation, usually we do 30 to 35 watts for about 60 seconds per spot. Because the idea here is not to ablate just atrial tissue, but to ablate through the atrial tissue within the fat pads where the ganglia are really located. And here you can see it goes all the way up to 100 beats per minute just by ablating in this specific area. You see in this map, there's been reconstructed the fat pad in green, This is the area of ablation of the left atrium that is opposite to the fat pad. And here you also see the phrenic nerve. And the green dots are high pacing, high output that shows proximity to the phrenic nerve. So here, another example of anatomical ablation. Again, the way this is done, typically we start from the left side first, after we go transeptal, and then we ablate opposite on the right side. Usually we do see even more response when you do biatrial ablation. Whether you really need biatrial in every single patient is really unknown, because we've always been doing biatrial, but there is some data from Europe, from the Bruin, where you can actually just use maybe a right atrial approach in some of these cases. And I think if you probably limit the ablation, you may have less inappropriate sinus tachycardia, which is a complication of this procedure, but we've always been doing biatrial ablation for all of our cases. All right, so after ablation, repeat vagal stimulation shows no change in the PP interval, no change in the PR interval, so we're quite happy because we have an objective endpoint. And again, this is really an important innovation from Professor Pachon that we've been incorporating here, because it makes our procedures endpoint much more reliable and understandable. At the end of the procedure, we always also add atropine just to see if there is any residual vagal innervation that we have missed with extracardiac vagal stimulation, but usually we don't see any type of response after ablation. Our first series has just been published. We have a series of 17 patients. These are the clinical features. You see the PP interval, PR interval at baseline and after the procedure. Typically, we do see a shortening of the PP interval. The PR interval doesn't shorten that much, but again, in this series, most of the patients had sinus arrest, the clinical manifestation. AV block was only a minority of them. And here are the outcomes. With 17 patients, 76% with sinus pauses, 16% with AV block, one patient at both. All patients with a baseline provocable sinus pause or AV nodal block with extracardiac vagal stimulation. The target fat pads could be easily identified within really a few minutes in all patients, and were close to the septal left atrium or right atrium, covering an average surface area of about 3 centimeters square in the left atrium and similar in the right atrium. We saw more than 25% shortening of the PP or PR interval within the first 1 or 2 RF lesions at the center of the fat pad, and usually we start from the right superior pulmonary vein region. And in all cases, we have ablation of vagal responses via ECVS at the end of the procedure. The median follow-up was relatively short, which is a problem with this study, but of course we are extending follow-up now, 12 months. 94% were free from recurrent symptoms. 1 patient required reduced CNA. I'll show you the tracing in a second. And 1 patient ended up getting a pacemaker because asymptomatic diurnal AV block, and the patient wanted a pacemaker at that point. All patients had an ILR. Interesting finding was a young patient, 25-year-old, 1 year after CNA, had new onset paroxysmal atrial fibrillation. She never had that before. And I wonder if unopposed sympathetic innervation is actually bad. I mean, the vagal nerve is not only the reason why people go in FA, but we use isoproterenol in the EP lab to induce atrial fibrillation. So maybe some of these procedures may even be pro-arrhythmic in some patients. So here is an interesting finding, a patient that underwent repeat cardioneuroablation. The clinical manifestation was sinus arrest before the procedure, so we limited our ablation to the right superior fat pad, paraseptal region. But then the patient came back with a syncope again, actually pre-syncope. But you see here, the manifestation now is entirely heart block, because the PP interval does not change during this event, suggesting that the vagal activation really is only seen by the AV node, and the sinus node is being completely denervated. It's something that we've seen over and over again now as we expand with our cases. So in conclusion, a nice guided CNA anatomical approach that identifies and reconstructs the target fat pads within the Waterston groove is feasible and is associated with good acute and midterm outcomes. Larger studies with longer follow-up duration are needed to determine whether this is durable and whether this is safe, because of course the effect that we have with bilateral ablation is quite significant, because we target directly the source of the problem, which is the fat pads, with this technique. Thank you.
Thank you. Excellent talk. I think that we need to get guided to that kind of procedure, because we arbitrarily need to identify real fat pads, which are really important to target, right? So I don't like this just pure anatomical approach and get like, okay, it's like right upper and whatever, right? So I think it's a very interesting approach. Do you have any questions?
In my opinion, whatever technique you use, if you check with extracardiac vagal stimulation the effect, then you have clear endpoint. And if you have clear endpoint, it doesn't matter which technique you use. This is my view of this problem. So I think it's elegant endpoint strategy where you can always check, even after one burn, you can check the endpoint.
And usually it's amazing because we've been checking after 1 or 2 burns. It doesn't take that much to eliminate that ECVS response, but we still do more. I think at the end, the area that we ablate is similar with different techniques. Otherwise, we would have different outcomes. But I think this makes it a little bit more reproducible because all the softwares for fractionation and other things like that are complicated because it depends on the wavefront, depends on the catheter, and so forth. So
John has also data that it depends if you stimulate left or right vagus. So you can eliminate a right vagal response, we can still have left vagal response. So if you want to achieve really complete denervation, you have to probably stimulate both. So but it's an elegant test. I think we should all centers should adopt this test because this is proof that you did what you intend to do, and it's a different from other strategies where you do something like renal denervation. You do something and you don't know. Okay, thank you, Pascal.
Hello, good morning. Thank you. So let me introduce our early experience with the Affera system and Sphere 9 catheter for cardioneuroablation. So this is our previous experience. We are doing cardioneuroablation since 2018, and you see until June of the previous year, we used like normal and typical systems and RF catheters for these ablations. So the total cohort of patients treated with Cardor inside and these catheters was 155 patients. You see typical average age, which is about 40 years, more males, and you see the procedure time, which took around two hours, and I would say atypically long RF ablation times. So the aim of this study and what we are now trying to get information from the Affera experience is that we would like to know if it's feasible, if it's safety, and if there is good efficiency if you use this system and this catheter for cardioneuroablation procedures. So we are collecting procedural data, but also we want to have a clinical results in follow-up. Maybe the advantage of this catheter, if you create RF lesion in comparison to a regular RF catheters, is that because of large footprint, you can do a larger lesion. You can do it definitely larger in terms of width of the lesion, maybe slightly deeper, but definitely it's much faster in 5 seconds. So what is our strategy? The strategy didn't change with Affera system. So we do our procedures in general anesthesia. We normally introduce or do 4 femoral punctures. We use 2 decoupled catheters for jugular veins, for vagal stimulation. We use intracardiac echo, and we use ablation catheter as well. So we start with this provocation, with the high-frequency stimulation in both jugular veins. So we have the Passion system. Then we are doing with Sphere 9 catheter left atrium map and right atrium map. And we are doing anatomical approach for ablation. So we are trying to cover typical lesions for superior paraseptal ganglionated plexi and inferior paraseptal ganglionated plexi. So the RF lesion, what we use normally is 5 seconds. We are trying to do maybe to do longer lesion with 7 seconds. And after this lesion set, we are testing again from jugular veins if there is some kind of reaction. And the end point of the procedure should be complete, no reactivity for this high-frequency stimulation. And you see, this is a group of patients treated with the Affera and Sphere 9 catheter for cardioneural ablation since June 25 until April this year. The total number of ablation is 39, a little bit higher age, average age 47 years. And you see the main indication. The indication as a diagnosis for treatment for level of sinus node dysfunction or AV node dysfunction. So you see 21 patients had like a combination. This was the indication, combination on the level of on sinus node and AV node. 14, they had the indication just for sinus node ablation, and an AV node, like AV blocks in 4 patients. There were also some patients, and like a third of our cohort, when we use this catheter mainly for ablation of AFib or AT, and we use it also together for cardioneuroablation together. So it was as a concomitant procedure. So this is the example, left atrium anatomy created with this system. We are now in the typical spot, and you see if you start the application, there is a really very fast reaction. You see how quickly the heart rate is changing and increasing. So it takes just 5 seconds, and you have nice response, very fast. So, and this is also here in the picture, not in the video. So you see the previous, before ablation, that is the heart rate 66 beats per minute. Here is the beginning of applications, 5 seconds, and there is immediate reaction and really prominent change in heart rate. And also this is a typical fractionated signal what we see here in this spot. Now, then we go for the area for inferior paraseptal ganglionated plexi. We always use intracardiac echo, and I think this is a good combination, not to rely on the anatomy, which we are creating with the system, mapping system, but also you see how nicely the catheter is sitting on the pyramid region, and during the application there is no any movement, so it's very, very stable, and I think you can navigate it together with the anatomic system with intracardiac echo. This is the lesion set typical on the right side. We normally do biatrial ablation, so you see lesions, I don't have arrow, sorry, lesions in superior vena cava. We are trying to avoid ablation close to phrenic nerve, and here is the lesion from the right side, close to, on the pyramid region, like close to CS ostium. And this is the final set, or maybe a different view in the same patient, and I told you that we normally do this kind of sandwich ablation. It's visible again, right-sided location of the catheter on the pyramid region. So here we have our procedural outcomes. Finally, 39 patients were treated with this approach. In this cohort, the indication only, the cardioneuroablation was 27 patients, and the concomitant procedure, cardioneuroablation and AFib AT ablation, we did in 12 patients. Here we have endpoints, so in total cohorts, so we were able to get any reaction for vagal stimulation at the end of the procedure in 92% of patients. But if you see just the cardioneuroablation cohort, the success rate was 96. Just one patient had some kind of response to this vagal stimulation at the end of the procedure. We didn't see any complication. Finally, we didn't make any damage, any injury to right phrenic nerve. You see majority of these patients were treated with biatrial approach, and in those we did ablation just from left side. It was in the group of patients with AFib or AT ablation. Here we have procedural outcomes in terms of heart rate. So you see there is evidently significant increase in heart rate before ablation and after, and also there is a change in PQ interval. So here we have the group only of cardioneuroablation itself, 27 patients. Procedure time was 90 minutes. Fluoroscopy time, we use fluoroscopy mainly for CS catheter introduction into jugular veins. RF time, just less than 1 minute. So this is about 10, 11 RF application. And this is what we saw, the heart rate and PQ interval changes. Success rate was, I told you, 96%. One patient had at the end still, there was a provocation of AV block. And I can comment later, maybe during discussion. This is the comparison of our cohort, and this is the last cohort of patients treated with Smart Touch catheter CARTO. So it's 30 patients and 27 patients to compare. So you see, with the Affera system, we can make the procedure shorter, and definitely the procedure time, it's much shorter significantly. And I think that's all from this. This is just example because one set of our patients in this group had a implantable loop recorder. So this is the example how it works. You see there is this line shows the day of ablation, and finally after this ablation it's visible how the average heart rate during day and night is increased. And there is also change opposite with heart rate variability. This is an example of a patient we saw after there were some clinical or asymptomatic AV blocks, but this is just during the night. So we started with this approach in a half of the year, of previous year. Finally, we have now 16 patients with 6 months follow-up. We had no symptoms in these patients from ablation. There were some asymptomatic findings. I showed you the night AV block in the previous slide. So 2 patients had documented AV blocks during the night thanks to implantable loop recorder. In one patient, we had information about AFib. Nobody from these patients needed pacemaker implantation. There was no reablation. And here we have a comparison of heart rate before ablation and the follow-up in 6 months. You see there is a still significant heart rate increase. So there are some, of course, limitations we can discuss later. We still have just like early experience with small number of patients. Mainly we have procedural data. Now we are collecting follow-up. We still don't know what should be the optimal RF ablation setting. If it's just 5 seconds, should be 7 seconds, or should we prolong maybe for 30 seconds? This is what we don't know, because definitely if you use a different, like 30 seconds, 60 seconds of ablation, you can go deeper. So, but finally, these applications are now used for RF ablation in ventricle. And of course, this is the larger footprint, so the area of ablation is larger, so we have to be conscious about possible phrenic nerve injury, and it's maybe a bigger problem because these patients are young. So it is just the anatomy that we have to, that we are very close from both sides to phrenic nerve, so be very careful. There is no response to if we need with this system really biatrial ablation, and we don't have a long-term effect. So let me conclude. Cardioneuroablation using this Sphere 9 catheter and Affera system seems to be, from our early initial experience, feasible, safe, effective. You have noticed significant shorter ablation and procedural times. So we have wider lesions, so we don't know if there's a high risk of larger collateral damage. And I think finally it's the best strategy if you have a bradycardia and AFib disease together. So use this catheter for AFib ablation. You can use RF-PF and then finish with RF ablation in predominant spots for ganglionated plexi ablation. Thank you.
Gonzalo, thank you. We have a little bit delay. Actually, I have one point. I noticed that we have a little bit older patients. Do you think that this certain group is because like it's a concomitant procedure with AFib, or can you comment?
Maybe, yeah, can be because one side of these patients were treated also for AFib AT ablation, so the average age can be influenced by this, yeah, can be. But still, 40 years of age or 45, this is the typical age for cardioneuroablation in our group, even with like previous RF catheter strategies. So.
I think you create bigger lesion, as you said, so I would really like to know if you try to do just the right-sided approach, because this may penetrate and it maybe avoid going to the left. This is one comment. The other is you may over-ablate. So I saw that there was one patient who had rise of heart rate from 50 to almost 90 something. So maybe these patients may feel then this inappropriate, or let's say for them inappropriate tachycardia or inappropriate heartbeat, let's say. So do you have any experience like that, that they complain of rapid heartbeat afterwards?
Yeah, thank you for the question. So we didn't test just right atrial approach. I still don't know if we can do it with this system, because the lesion is wider, but maybe not too much deeper than with normal ablation catheter. So I still think that if we do maybe randomization, that finally we'll have better results with biatrial approach. And for the second question, it was visible in this example that like very like prominent increase in heart rate. But, you know, even with normal, regular RF catheter, if there is such kind of this response, it's then going a little bit down. So also in this patient, the heart rate went down a little bit. I don't have any like information or data about clinical situation in patients that they would complain about really excessive tachycardia and their feelings. So we didn't use in these 16 patients in a 6-month follow-up. We didn't use any beta blockers to treat this. So yeah, this is my reply.
Okay, if there is no other questions, so last presentation is by. Thank you very much.
Thank you. Thank you.
We come back to you. We come back to you.
Yeah.
So last presentation of this session is Fast and Curious Neuroablation Pulse CA Approach, Tips and Tricks. Sebastian Stetz.
Thank you very much. Thank you for making the technical problem off. And all pictures will be with patient acceptance for this presentation, and I will show you our experience. I have more than 80 years experience with cardioneuroablation that I was taught by Professor Pachon. So some tricks and tips from Polish Registry on Cardioneuroablation. Of course, polka is a name for Bohemian national dance, so I don't want to convince how to dance. Maybe those guys will show you. I wanted to use Fast and Curious as an example of that may be the appropriate approach, and I changed it in Fast and Curious, and I want you to convince that all the guys from these pictures should be interested in doing this fast and efficient way. Of course, we have a polka. Polka is also female comes from Poland, so this is one of the Barcelona team, Polish guy, Polish lady. And for sure, extracardiac vagal nerve stimulation is the electrical adenosine for both nodes, sinus node and AV node, and we use it for the final assessment of the patients from the right and from the left. You can also see that on the left side, you can sometimes have an AV block with P wave, sinus P wave, and no direct influence on sinus node. So the goal was to change our strategy after almost 400 cases. In January 2015, we decided to improve our approach with experience, and we call it electroanatomical mapping because we assess still simple P waves and stimulus to QRS complex during incremental lateral pacing and pacing from the CS. So you can see that also some of the patients have an inferior P wave, flat P wave, and positive P wave, which is important because you can also, in general anesthesia, you can change the tail, the sinus node activity and then improve it. And the second one is just assessing 600 millisecond pacing from CS, that you can also see the high rate variability after the not only corrected sinus node refractory period, but also the stimulus to QRS, and then the variability of P wave. And we will see this during the live case presentation. So I will show you that another issue is the high power short duration, and we changed the strategy into the high power 45, 50 watts for only 15 seconds in the spots, and 5 GPs starting from the left, then to the left inferior, then to the right superior, and then back on the right side. And as you can see, we decreased the time of procedure to 55 minutes. It's currently about 45. And decrease the radio frequency time. And the most important is decreasing the time of procedure, the first pass binodal denervation, assessing by bilateral vagal nerve stimulation. So we really have a high rate of binodal first pass denervation. And there was a similar recurrence rate during the 6-month follow-up. So this is a high power short duration, including in the approach will help you. But we have also not so fast cases, and majority of the patient has a problem with a permanent pacemaker. They are good also coming to this procedure and previous TLE or cardiac surgery procedures. And you can also expect after 500 cases, we have 5 difficult cases, and I will show one. Another trick is to use the retrograde vagal nerve internal jugular vein cannulation using ultrasonography, and we find it in 5 cases very needed, and especially if you have a blockage in interruption between superior vena cava, brachiocephalic vein, or subclavian. But of course, you can use it unilateral access from the subclavian. You can use it from opposite side, contralateral, and sometimes by permanent left-sided superior vena cava. So you have another tricks from this experience. And this is another group of already presented in HRS, the patients that come for the cardioneuroablation with pacemaker. We found it 36 patients from our group of 500, and we decided to do the procedure, then to validate within 2 months with invasive assessment, and then proceed for explantation. Until now, we have 32 patients already explanted for waiting for the explantation with only 1 tamponade, and the long-term follow-up over 3 years is very successful because nobody needs extra cardioneuroablation or reimplantation. 4 patients who were not sent for TLE because of shared decision-making. Decision was to wait for the area and prolong the decision for the patient. It's also okay. So this is the example of the one lady that is complex. The lady was implanted due to the recurrent syncope. It was like vasovagal storm, and the patient was given the DDR, and they have immediately after 1 month cardiac tamponade and atrial lead perforation and reposition. And after 9 years, the lady comes and wished to be cured and explanted. So we decided to do the cardiovascular autonomic test with a pacemaker off, and we we can see by this test that the patient has active disease, so sinus arrest plus sinus bradycardia prolonged for 10 seconds. We gave her atropine, and of course you can see that before atropine you have 70 beats per minute, and after atropine you can have a rise in sinus rate, but you can also use NIPS for validation of AV block, so you can use it. And we start the procedure, and we realize there is no connection to the superior vena cava from superior, from inferior. Fortunately, it was a PFO, so we did a procedure. We start from the retrograde subclavian access to the right internal jugular vein, and we realized that we can proceed with almost all GPs except of the part of the right atrium, superior atrium. As you can see, it's something like here, and this is the membrane that was inside the right atrium done by previous, that induced after healing of previous tamponade, and of course we cannot cross it. And of course we ordered a special team to validate this, and it was veno-azygos vein. It was completely interruption between the right atrium to the superior vena cava, between superior vena cava to the brachiocephalic vein. You can see the huge bypass graft from the bypass circulation of the contrast, and of course the patient was accepted for TLE with a ballooning of the superior vena cava, and azygos vein flow stopped, and the patient was then stented from brachiocephalic vein to subclavian vein, and patients after follow-up is okay, and the patient also lose swelling in the face and neck because it was borderline superior vena cava syndrome. So this was one of our cases, and if correctly planned with imaging modality, you can recognize the problems, and I will recommend to use this. Of course, you can this approach. You can also use the zero fluoroscopy cardioneuroablation with vagal stimulation by, as shown by Professor Clark, but it takes almost 4 hours. It's very difficult for us. You can use another energy. This is the case without syncope, but the patient with sinus bradycardia permanently absent, as reported by his wife. And of course, we discussed only with wife. The man was very cognitive dysfunction, and he had a orthostatic challenge, tilt testing, and that almost killed him. He never fell down, but almost killed him. But we gave him atropine, and we do the bipolar cardioneuroablation in the sinus superior paraseptal GPs, and we were lucky to get it very, very quickly within 90 seconds, 3 bolus application, 3 together applications, and we have a selective sinus node denervation. But still, you can see the distance between those catheters, and of course, we need a coronary angiography, and on MRI 7 days after, we saw just small spot of the lesion. And we can also have another problems, the long-term recurrences. This is the example of our third recurrences after the previous 3 procedures. The patient was accepted for, again, vasovagal storm with severe documented sinus arrest, and we gave him atropine. It was still positive. The patient was sent to our consultation again. So what we should do the atropine pump forever, or tablets. We have tablets with atropine in Poland. We should pace him according to current guidelines. We should do the leadless pacemaker, endo-RRR CNA, or endo-RRR CNA with bipolar, but already he has the bipolar as a second procedure. Or we should send the patient to Brazil to Professor Paixão to do something else, or to the ECAM. And of course, we discussed with the patient what to do, and the patient was sent for the epicardial reconnections and hybrid approach ablation. With shared decision making, he decided to do it. He doesn't want any kind of pacemaker. And we did a transfer for the rescue epicardial hybrid cardioneuroablation with more defined sinus node sparing hybrid ablation. This is the procedure that it can also be used for the inappropriate sinus tachycardia. So we manage this. We do the left retro internal jugular vein ultrasound guided vagal nerve pacing with a cannulation, and the baseline vagal nerve stimulation showed there is nothing from the left, and of course we can see only from the right, so we do the right atrial intercostal space access, and we do by clamp, atricute clamp, the procedure with isolation of crista terminalis plus superior vena cava, and after the procedure, patient get no vagal nerve stimulation. We use also prostaglandin. If you have a problem with atropine, you can use a prostaglandin. And I will show you the live case from Sanok. Sanok is most anti-arrhythmic town over the world because the name is SNA Note OK. So it's like a normal sinus rhythm. And this is the example of our day. We start very early, like in ICAM, from 7:20 with electric storm. Then we do the 3 cardioneuroablation, which each lasted skin to skin about 40 to 60 minutes, door to door, maybe longer, with a less ablation time. And I will show you our checklist and our approach. I will leave it here because of shortage of time, but you can also assess this from the presentation, our checklist, how to do it smoothly and very efficiently with a still curiosity on stimulus, QRS, on P waves, and on the reflexes from the GPs during the procedure. Thank you.
Thank you very much. Any comments, questions?
Actually, I can continue with Joseph's question. Have you seen any appropriate sinus tachycardia?
Yeah, of course. If you manage the patient and control them very often, you can also see the borderline East symptoms. So we, for the first 3 months, we gave even the patients the ivabradine for the 90 beats per minute resting rhythm. But of course, you have less than 1% during the long-term follow-up, and we have at least 0.3% that is requirement for the sinus node modification by hybrid approach. With a series of more than 600 patients, we have 3 patients that already was accepted because of failure of anti-arrhythmic drugs.
That how to manage, because we have one example from outside the hospital. The lady is very young. She got really classic appropriate sinus tachycardia after CNA, and they blade sinus node, and now we need to deal with completely like asystole, right? So the problem is how to manage this patient. So she must get probably lead a pacemaker.
Yeah, but she's in sinus tachycardia or not? Right now, it's not.
She is like, like asystolic.
Systolic, so it's a complication of this. We try to do it with a sinus node sparing procedure, with not directly assessing targeting the sinus node, is rather the isolation of the right atrium, and then with control of that we can control the sinus, inappropriate sinus tachycardia.
Okay, thank you very much. We decided to have now 15-minute break, and then we continue with live cases and final presentation immediately after. So please, 15 minutes.